Bismillah ar-Rahman ar-Rahim. I'm going to talk about ASD consensus on risk stratification for people with diabetes fasting during Ramadan, an overview. And this is a publication with the name Risk Stratification in People with Diabetes for Fasting During Ramadan, a consensus from Arabic Association for the Study of Diabetes and Metabolism. And let me acknowledge the very hard work of dear professors and colleagues, starting with Professor Amin Roshdi, Professor Amr Abdel Wahab, Professor Amr Al-Meligi, Professor Hani Hamad, Professor Shireen Abdel Ghaffar, Professor Atif Al-Bahari, Professor Nasser Taha, Professor Nihal Hamdi, Professor Amr Gad, Professor Layla Hamouda, and Dr. Shayma Abdel Maboud, and myself. The current international guidelines recommend a pre-Ramadan risk assessment for people with diabetes who plan to fast during these holy months. However, a comprehensive risk assessment-based recommendation for management of people with diabetes intending to fast is still controversial. Therefore, the Arabic Association for the Study of Diabetes and Metabolism developed this consensus to provide further insights into risk stratification in people with diabetes intending to fast during Ramadan. To fast or not to fast, this is the risk stratification, and despite of the plenty of publications related to Ramadan fasting, the risk stratification remains controversial. And our consensus is a very huge publication, but this is the summary in this table, and let me start with some topics mentioned in this summary. We divided the groups into 4 groups: very high-risk patients who must not fast, high-risk patients who should not fast, moderate-risk patients who fast with medical support or medical assistance, and low-risk patients who can fast easily with no complications. And also we divided into groups according to the type of treatment, whether oral therapy or injectable therapy. And for oral medications, there was no very high risk or high risk patients. And we are going today to have a lecture about oral therapy and who should fast and with little medical assistance and who is safe to fast. And then the injectable therapy, and Professor Amr Al-Meligi is going to discuss this topic in details. Then we will shift to people with special situations like pregnancy and lactation, and I'm going to talk about them, and old age also, and I'm going to talk about this topic. Then Professor Shireen Abdel Ghaffar is going to talk about type 1 diabetes, who must not fast and who can fast. This is debatable. Then the acute complications, and the acute complications, all of them are considered very high risk for fasting: hypoglycemia unawareness, recurrent or unexplained hypoglycemia in the last 3 months, GKA or hyperosmolar coma in the last 3 months before Ramadan. And all guidelines are considering all these acute complications as very high risk for patients to fast. Then we're going to talk about macrovascular complications in a separate lecture, and cerebrovascular disease, peripheral vascular disease. Professor Amr Gad put this risk stratification for the vascular disease: patients with acute limb ischemia or chronic limb ischemia, diabetic foot infections, and recent DVT within 3 months. All these patients are considered very high risk to fast. while those with compensated chronic limb ischemia and non-infected diabetic foot ulcers are considered moderate risk to fast. Then we're going to talk about microvascular complications, and my colleague, Professor Hani Hamed, is going to talk about patients with chronic kidney disease and possible risk stratification for those patients. Diabetic retinopathy, those who are considered very high risk to fast are patients having sight-threatening diabetic retinopathy. And Professor Laila Hamouda, professor of ophthalmology, was responsible for this part. The diabetic neuropathy, again, we're going to discuss today, and we have general considerations. The general considerations are the level of hemoglobin A1C. If more than 10% with hyperglycemic symptoms and or pre-meal blood glucose level more than 300, this is considered very high-risk patient. And if hemoglobin A1C between 8 to 10% with pre-meal blood glucose between 150 and 300 is considered high risk. And for moderate risk, hemoglobin A1C less than 8%, and for low risk, hemoglobin A1C less than 7%. Again, the physical work, if patients are hard physical work, this is their lifestyle, then if they are on more than one insulin per day, they are considered very, very high-risk patients to fast. For hard manual work itself alone, it is considered moderate risk. Also, the hot climate, because some countries are very hot during summer and with no air conditioning, no facilities, then the prolonged exposure to hot climate is considered a moderate risk. Fasting duration more than 16 hours is considered moderate risk, and non-compliance to fasting is considered moderate risk. And these are some general considerations. If the patient is having 2 high-risk factors, this candidate will be considered as very high risk. If 5 moderate risk factors, this candidate will be considered a very high risk. If 1 high risk factor with 3 risk from the moderate group, this candidate is considered very high risk. Then there is augmentation of risk factors, because if the patient is having just 1 risk factor, maybe he's not a very high risk, but when added another risk factor, this patient can move to the very high risk. In the presence of 4 moderate risk factors, this candidate will be considered among the high risk group. Let me now shift to the pregnant ladies. And this is a case scenario. Mrs. Mona, 28 years old, type 1 diabetes since 4 years. Now she's pregnant in her 3rd month and wish to fast next Ramadan. Mrs. Noha, 36 years old, discovered to have gestational diabetes during the 5th month of pregnancy, and she wished to fast next Ramadan. And these are the glycemic targets during pregnancy according to the American Association of Clinical Endocrinology and the ADA guidelines, and we can find that the targets are very tight for preprandial less than 95, 1 hour less than 140, 2 hours less than 120, and in patients with pre-existing type 1 or type 2, the pre-meal and bedtime and overnight glucose between 60 and 99. These figures are actually impossible to achieve, and they need CGM, for example. And patients are more prone to hypoglycemia, and hypoglycemia is a very high risk during pregnancy because pregnancy itself may be associated with impaired counter-regulatory system and hypoglycemic unawareness. And there is failure in the physiological protective mechanism against hypoglycemia during pregnancy. Around 45 to 70% of type 1 diabetic women experience severe hypoglycemia during pregnancy, and severe hypoglycemia can occur during pregnancy 3 to 5 times more frequently in the first trimester and at a lower rate in the third trimester. The effects of hypoglycemia on the fetus is controversial, and there is possible role in teratogenicity. Low levels of maternal glucose during pregnancy may cause fetal growth retardation and small for gestational age infants. Maternal hypoglycemia may also determine impaired fetal beta cell function. These are some problems during pregnancy: placental insufficiency with hypoglycemia, GKA, which may be fatal to the fetus, neonatal hypoglycemia, very high incidence rate of severe hypoglycemia, between 19 to 44% have been reported in diabetic pregnancy. A study on type 1 diabetic patients, females, found 45% experienced episodes of hypoglycemia, particularly during the first and second trimesters. The decreased blood glucose level in pregnant women may affect fetal outcomes. For example, it may affect fetal growth retardation, small for gestational age, and impaired fetal beta cell function. And the hazardous effect of recurrent hypoglycemia on the adult brain is a well-known complication. However, there is no available data on the long-term effects of recurrent hypoglycemia on fetal brain health in the future. Therefore, we cannot guarantee the safety of maternal fasting during Ramadan on long-term fetal brain health. Merghani and Hamid found a higher rate of induction of labor, cesarean section, admission to special care unit of the newborn in fasted group compared to control group. Diabetes or gestational diabetes during pregnancy increase the risk of unfavorable maternal and fetal outcomes. Therefore, women with diabetes who become pregnant are instructed to avoid Ramadan fasting. Fasting in lactating ladies, this is also controversial. Regarding breastfeeding, data suggests that women with diabetes may experience hypoglycemic events during lactation. Therefore, they are advised to eat before or during breastfeeding to avoid hypoglycemia. Achieving desired metabolic control in fasting lactating women during Ramadan is challenging. And this is the summary of recommendations according to ADA consensus. Pregnant ladies with diabetes, whether type 1, type 2, or gestational diabetes, are considered very high-risk group and must not fast during Ramadan. Lactating women with diabetes who are not taking insulin are considered moderate risk and may fast during Ramadan with medical supervision. And lactating women with diabetes on insulin therapy are considered very high-risk group and must not fast during Ramadan. And this is the table mentioning the groups of very high risk and the groups of moderate risk. Thank you very much.